Hello, everybody. Welcome to Grand Rounds this day. I apologise for the delay in starting. We've had a few technical problems or audiovisual problems setting up the system in the auditorium rather than in the main theatre in the hospital. But today we're going to have some interesting information about the CF revolution. The presenter will be Yashneel Prasad, who is one of the new sleep and respiratory doctors here at Canberra and Calvary Hospitals, who has a special interest in CF, cystic fibrosis. So he's going to tell us all of the exciting new developments about the management of patients with cystic fibrosis. I think we're having a case presentation first.
Just a couple of minutes.
Okay, so we'll start off with a case presentation.
Thank you, Dr. Prasad, for allowing me to start the discussion with a case presentation today. My name's Eli. I'm one of the basic physician trainees, maternity leave at the moment, and I'm Eli Dunn. Today I'm talking the case presentation is Mr. J.E., a gentleman who has consented for his story to be shared today. He's a 30-year-old ABC political reporter, journalist with cystic fibrosis, and who has had, despite his young age, declining respiratory function and an increasing symptom burden. His journey started at birth, where he was screened for cystic fibrosis with the blood spot. It came back positive. Subsequent analysis revealed that he was Delta F508 homozygous. No family history. His brother doesn't have cystic fibrosis. His family, his parents were unknowing carriers. He had a fairly typical childhood for someone with cystic fibrosis, where he started chest physio in infancy, daily nebulization of hypertonic saline and DNAs. His school was broken by frequent chest infections and hospitalizations. Studying for his high school certificate on the ward, and then left and sat his exam the next day. His despite this, he passed his HSC and went to university and studied journalism. He had some hobbies, although he wasn't able to engage in many other team sports. He did have hobbies such as surfing and his love of creative art. In addition to his pulmonary manifestations, he had extrapulmonary disease associated with his cystic fibrosis, including exocrine dysfunction of his pancreas. His endocrine function was intact, and he's been on Creon since he was eating solids. It's significant abdominal bloating and steatorrhea and abdominal pain. That, in addition to quite severe reflux since childhood, has led to significant malnutrition that he's battled with most of his life. It's maintained on, he still takes a lot of the normal vitamins we give someone with cystic fibrosis and exocrine dysfunction, as you can see there. Had some hepatic steatosis, which is probably related to malnutrition early in life, and no other hepatobiliary disease associated with his cystic fibrosis. In addition to that, he also has bilateral absence of his vas deferens. Hasn't bothered him in the past, but now with a long-term partner who's interested in family planning, it presents another issue for him going forward. His other medical history includes asthma that was diagnosed in childhood. He's never had allergic rhinitis or any allergies, eczema. He does have a strong family history and some eosinophilia in his blood work. This has been well managed with fluticasone and salmeterol, some prednisone in childhood, but nothing recently. He's been diagnosed with a major depressive disorder at the age of 24. He did have some depressive symptoms prior to that, however. Primary stresses of his chronic disease impact on life. His work was vulnerable because of time taken from work and lack of sick leave. Impact that has on finances, affording housing, and ironically, that has impacted his ability to access psychology, even on healthcare, GP, mental health plan. He felt that was financially unachievable. He's had pharmacotherapy with sertraline and subsequently agomelatine, which he remains on at the moment, that change was related to medication intolerances or interactions with his CFTR modulation. Dr. Prasad will talk about it in a moment. He's also had migraines throughout his 20s, managed with paracetamol, quite burdensome. He saw neurology this year and has just recently been started on a triptan to manage that. He's not on any prophylaxis. In addition to that, with regards to his social history that I haven't mentioned, he's a very well-educated fellow. He's a great understanding of his disease, takes a lot of ownership of his healthcare, reasonable compliance to his prescribed therapy. Is impacted by depression associated with chronic disease, but has no high-risk activities such as smoking, no recreational substances. His preventative healthcare is up to date. He's due for another COVID vaccine, but his vaccinations are up to date, and he's had a recent bone density scan that's reassuring. He was referred to our service in 2018 at the age of 24. At the time of referral, he had established bronchiectasis. His FEV1 that year was in the order of 50% of his predicted or moderately reduced. He's already chronically infected with Pseudomonas. This was a multi-resistant organism, resistant to carbapenems, aminoglycosides, fluoroquinolones, Trianam, was pan-resistant, in addition to other organisms that were identified in sputum over the next few years, which are typical for cystic fibrosis. He was experiencing yearly infective exacerbations at that time, mostly managed as an outpatient because of his obligations to work as on TV as a presenter at ABC. During his time here in Canberra, he was receiving optimal medical therapy, 3-monthly reviews with a cystic fibrosis multidisciplinary team. He was getting daily physio at home that he was doing himself. He was using his PEEP device or PariPEP device, nebulizing his saline, using his DNAs. Prescribed low doses of azithromycin and a Tobia inhaler for suppressive therapy associated with chronic pseudomonal infection. And he had he was prescribed some CFTR modulators, which Dr. Prasad will speak about in his coming presentation. In the context of all of that, unfortunately, in April 2022, he had a life-threatening pulmonary hemorrhage complicating his bronchiectasis. He was admitted to hospital and he was needed empiric embolization and was admitted to ICU following that severely hypoxic, had a longer hospital admission with antibiotics and hospital in the home. That episode was in the context of a general downward trajectory. His FEV1 in the last 24 months had been frequently below 40%. Increasing disability, often finding himself out of breath walking up a flight of stairs. He was persistently at a low body weight. His nadir for his BMI was 19, often around 20 despite attempts to gain weight. And in the context of that chronic disease, he had significant psychosocial stresses and worsening mental health. And in that context, he was starting discussions about what transplant would mean, what the referral would be, and what implications that would have on his life. It's at that point, where this low point, that I'll finish the case presentation and hand over to Yash, who will provide an update on this gentleman after he's explained some of the novel CF therapies. Should be able to go. Okay. It's the present button.
Cool. Thanks, Eli, for that smooth presentation. I have no doubt you're going to cruise through any CF long case that comes up in the next month or so. Okay, despite this being an adult grand round, I'm noticing a lot of pediatricians in the audience. I suspect my wife, who's a pediatrician on staff, had something to do with that. My presentation is about cystic fibrosis, but more specifically, I'll be talking about modulator therapy in CF, focusing specifically on the latest PBS-approved drug Trikafta, the evidence surrounding its use, and the background we need to understand how the drug works. So you might think that the title of my talk was a little dramatic, the CF revolution. So I thought I'd start off with this particular slide. It's an amalgamation of a couple of different registries, and the graph plots, I've got my pointer here. Yeah, The graph plots predicted survival on the y-axis against birth year, and it shows the phenomenal.
Using a mouse and
Oh, yeah, can I?
for the people that don't.
Oh, okay, sure.
This one.
It's this one. It's not. Oh no, here we go. Yeah. Oh, cool. That's helpful. Thank you. Yeah. So what sort of it shows the phenomenal increase in survival over the last few decades. And what's absolutely wild to me is that even in the 80s, when some of us may not have been born, but one or two of us may have already entered the medical field. But for a CF patient born in 1980, the expected survival was 20. That's wild. And I feel like I only really entered the CF world last year when I was asked to take over Prof. Hurwitz's CF clinic when he went on long service leave. And it's been fairly normal for me to see fairly well patients in their 40s, 50s, and we've got one in their 60s. But I'll never forget my first clinic with Prof sitting in the back of his room as he reviewed the patient that Eli just described, and Prof stared at the patient's pulmonary function test in disbelief and just said, "Whoa," over and over again for a good couple of minutes. So much so that I thought there was something wrong. And being aware that Prof entered the medical field in his 80s, I started to edge towards the met call button. But he was just shocked at how good things were. So this is just a little bit of basic information. It's not the focus of my talk today, and I don't plan to go into any detail about the disease process. But I appreciate that on a day-to-day basis, most of us have very little to do with cystic fibrosis other than attending a lecture in medical school and then dealing with it in our physician's exam. So as a brief recap, CF is a rare autosomal recessive progressive and lethal multisystem disorder. It ultimately affects sites where secretory epithelial cells exist. So that is the upper airways, the lungs, the digestive system, with downstream malabsorptive issues, sweat glands in the reproductive tract. And CF is unfortunately the problem of the respiratory physician, because despite being multi-system, progressive lung disease has been the major cause of morbidity and mortality. But part of me wonders if that will change and the predominant specialty involved will evolve over time. So it all comes down to this son of a gun, the cystic fibrosis transmembrane conductance regulator. I don't think we spend enough time talking about how cool a name that is. So CFTR is a cyclic AMP regulated chloride and bicarbonate channel that's expressed on the surface of secretory epithelia, so airways, pancreas, intestines, etc., which in turn regulates the activity of other electrolytes and water transport. The exact mechanisms involved and the ultimate electrolyte composition of the surface mucosa remains the subject of ongoing research, but the net result is alterations in the rheology, the fluid mechanics of surface mucosal fluid, which become thick and difficult to clear. The CFTR protein has two 6 membrane spanning regions, 2 intracellular nucleoside binding folds, and a regulatory domain with multiple phosphorylation sites. And cystic fibrosis is caused by mutations in a single large gene on chromosome 7 that encodes the CFTR protein. This CFTR gene spans 250 kilobases and encodes 1,480 amino acids in the mature protein. There are over 2,000 recognized mutations on the CFTR database that have the potential to cause disease. It's an unreasonable number to memorize, and I can only remember the sort of 1 or 2 most common ones. Now, there are a few different ways to classify CFTR mutations. They're not really all that different. I think this 5-class system is fairly easy to understand, and I promised as a point to this later as we talk about the modulators. So the first class refers to protein production mutations, which are typically nonsense and splicing mutations that result in no functional CFTR protein being produced. Class 2 refers to abnormal post-translational processing of the CFTR protein. This results in abnormal folding of the protein, thereby preventing trafficking to the appropriate cellular location and early cytoplasmic degradation of the protein. The third class, oh, sorry, before I go to that, the mutation that I'm sure we all remember is the F508, del or del F508, and this falls into class 2, and about and it's del F508 specifically refers to a deletion in the 508th amino acid in the CFTR protein phenylalanine. And about 50% of CF patients are homozygous for del F508 and 90% are heterozygotes. Now, class 3 mutations are known as gating mutations, and this leads to the CFTR protein being appropriately positioned on the cell membrane, but there's diminished activity in response to ATP, so there's reduced channel opening. The other commonly known mutation is G551D, and that falls into this category, but only affects about 5% of patients with CF. Class 4 mutations are similar to class 3 in that you have CFTR protein ending up in the cell membrane, but there is reduced ion conductance through the channel when compared to normal CFTR. And class 5 refers to reduced amounts of functional CFTR protein being produced. It includes mutations that result in unstable mRNA or unstable mature protein. Some other classification systems have a class 6, but it just divides class 5 into 2 classes. So I love a bit of medical history, but I thought it was also interesting reflecting back on the interventions that led to those incremental improvements in mortality that I showed you earlier. So this is my version of a brief history of cystic fibrosis. The first modern description of CF was in 1938 and initially had nothing at all to do with the lungs. Children, unfortunately, didn't live long enough to develop severe lung disease and instead died of malnutrition due to failure of the pancreas, which became scarred and developed cysts. And that's why the term cystic fibrosis has come about, which I've always thought is bizarre because you don't really develop cysts in the lungs in cystic fibrosis. It's a pancreatic cyst issue. In the 40s, the major therapeutic advancements were the use of primitive antibiotics. In the 50s, it was recognized that children with CF that suffered from heat prostration during a New York heat wave had increased salt content in their sweat, and this has eventually become the cornerstone of diagnosis around the world. Physiotherapy in the form of postural drainage and percussion started to enter the treatment paradigm, and so did a rudimentary form of pancreatic enzyme replacement. I'll skip the 60s and 70s for now, but just wanted to share an interesting treatment approach of mist tents where they grouped CF patients in these tents and got them to inhale humidified air in an attempt to help with mucus clearance, which is kind of similar to high flow nasal prongs, and did help with mucus clearance, but quickly fell out of fashion when it was recognized for the cross-contamination nightmare that it was. During the 80s, there was a gradual increase in the use of nebulized anti-pseudomonal antibiotics to stabilize patients that were chronically infected with Pseudomonas and with early Pseudomonas infection. We started to involve sort of a more of an allied health approach, and dietitians entered the mix. There was a development of a new acid-resistant pancreatic enzyme, Creon, and for severely malnourished patients, NG tubes, gastrostomy, and parenteral feeding became part of the treatment paradigm, as did lung transplantation. And it was during the 80s that the CFTR gene was identified, and someone came up with a fantastic idea of calling it the cystic fibrosis transmembrane conductance regulator. There were ongoing improvements in the 90s as a result of steady improvements in care and increasing expertise of staff with well-established CF centers around the world. The notable additions to treatment included nebulized recombinant human DNA, so pulmozyme, which is one of the first effective mucolytic agents. And then there was a new preparation of tobramycin and long-term azithromycin. And to cut a long story short, in the late 90s, 2000s, Vertex partnered up with the US Cystic Fibrosis Association and explored small molecule drugs directed at fixing the CF protein. and the 2010s have really heralded the era of modulator therapy, with the most dramatic changes in the last 2 to 4 years. So the current conventional framework for the management of CF patients is shown here. You'll sort of recognize it's very similar to one of Eli's slides. And it's by no means exhaustive and doesn't include all the screening we do for malabsorptive issues and complications of therapies, but centers around, for the lungs, airway clearance in the form of nebulized pulmozyme and hypertonic saline. A big part of this is also chest physiotherapy with breathing techniques, coughing techniques, and the use of devices, bronchodilators as well at the beginning of every chest physio session. We try and prevent infection through vaccination, and again, just the common vaccines, so flu, pneumococcal, and now COVID. Inhaled or nebulized tobramycin and colistin for chronic and initial Pseudomonas infection. And in clinics, much unlike the missed tenths of the past, we're quite militant about separating patients, and one clinic room will be dedicated to one patient for the entire duration of that clinic. We use anti-inflammatories in the form of low-dose azithromycin, and for patients with coexisting asthma, inhaled ICS, and for pancreatic insufficiency, enzyme replacement with Creon and vitamin replacement. So onto the CF modulator. One of the things that I think is really cool about modulators is that, unlike the therapies on the previous slide that really treat the downstream consequences of the mutant CFTR protein, modulators work on the protein itself. They improve the production, the intracellular processing, and the function of the defective CFTR protein. At the moment, we broadly divide modulators into correctors and potentiators. Potentiators bind to the CFTR protein in the plasma membrane, increasing the CFTR channel's opening frequency and thereby improving ion conductance. And so you can imagine for this, you need to have some functional protein already on the cell membrane. And you can imagine that it wouldn't work for all the mutations I described earlier. CFTR correctors help normalize the folding of the protein, and therefore its movement to the cell surface. And as you may remember, the del F508 mutation results in abnormal folding and premature degradation. So there's an obvious role for a corrector here. I'll brush over the other modulators before focusing on Trikafta. There are currently 4 approved modulators in Australia: Kalydeco, Orkambi, Symdeko, and Trikafta. Ivacaftor, brand name Kalydeco, is a potentiator. It works for the class. Where am I? Class. I think that. Oh, you'll try. There we go. So it works for the class 3 mutations here. So you have a transcripted gene that is translated in the endoplasmic reticulum and then transported to the cell surface. And at the cell surface, ivacaftor binds and helps with ion conductance. Sorry, I've just lost where I am. Yeah, that's right. And so ivacaftor, although it's been around for about 12 years or so, in that the first publication came out in the NEJM in 2011, it was only approved by the TGA in 2016, and it was rejected by PBS a few times, and was initially only approved for the G551D mutation, which again only affects about 5% of patients. Orkambi is a combination of ivacaftor, which we just spoke about, and lumacaftor, which was the first discovered CFTR corrector, which increased the trafficking of the CFTR protein to the outer cell membrane. It was PBS listed in 2018 and only approved for patients that are homozygous for the del F508 mutation, and really only resulted in modest improvements in FEV1, but a 30% reduction in exacerbations compared to placebo. It hasn't been shown to be particularly effective in del F508 heterozygotes. Symdeko is a combination of ivacaftor and, at the time that it came out, tezacaftor, which was the newest corrector, marginally superior to Orkambi, and initially only approved for del(F508) homozygotes, but this is recently expanded to a bit of an umbrella term called residual function mutations. So on to Trikafta. Trikafta was PBS listed just last year in April. It's a combination of the potentiator ivacaftor and the corrector tezacaftor and another next-gen corrector elexacaftor. The elexacaftor component increases the amount of mature cell surface protein compared to tezacaftor, and the combination of tezacaftor and elexacaftor have separate binding sites and act synergistically to improve its function. There's also some evidence to suggest that elexacaftor has a bit of a potentiator effect and increases conductance across the cell membrane. Trikafta was PBS listed following 4 key trials. I thought I'd just discuss a couple of them. The first trial was a 24-week placebo-controlled trial that enrolled about 400 patients aged over the age of 12 with at least one F508 mutation. It was a randomized, double-blind controlled trial. There were 2 arms, the placebo group and the treatment group receiving Trikafta, and the primary outcome that was measured was the absolute change in percentage of predicted FEV1. The results showed a change in percentage of predicted FEV1 from baseline to week 4 of 13.8 percentage points, and there was a drop in the placebo group of 0.2. And among the secondary outcomes that were measured, the percentage of predicted FEV1 was sustained at week 24 with a 14.3% improvement, and there was a drop in 0.4 in the placebo group. The number of pulmonary exacerbations from baseline to week 24 was 41 for the treatment group and 113 for the placebo group, so 63% lower, and this was again statistically significant. The second study evaluated the efficacy of Trikafta in patients with CF who were homozygous for del(F508), and this study enrolled 113 patients. It was randomized, double-blind and controlled. Inclusion criteria were patients over the age of 12, homozygotes, and having an FEV1 of between 40 and 90%. There were 2 arms of the study. 52 patients were treated with Symdeko, which is a Trikafta-ivacaftor combination, and 55 were treated with Trikafta. Again, the primary outcome measured was the absolute change in percentage of predicted FEV1. And the main thing I wanted to highlight was that the results showed that the change in percentage of predicted FEV1 from baseline to 4 weeks was 10.4 percentage points for the triple therapy group, and just a 0.4 improvement in the Symdeko group. Now, the reason that this is such a big deal is that, firstly, we now have 2 correctors working synergistically that have been shown to be much better than previous modulator therapies. But the biggest draw card is that we now have simple, effective oral therapy available for 90% of CF patients, which is a monumental shift from previous treatments. And just thinking back to our sort of conventional treatment slide from earlier, you can see the treatment burden that CF has on patients, and the introduction of Trikafta has allowed us to study the effect of cutting back on some of these treatments. So the simplified trial was a non-inferiority trial designed to assess the impacts of discontinuing versus continuing the chronic therapy, so specifically nebulized pulmozyme and or nebulized hypertonic saline in CF patients who are over the age of 12 with stable disease on Trikafta. And again, I just wanted to show that ultimately it showed us that lung function was relatively well preserved at 6 weeks despite ceasing nebulized therapies. There have also been some non-pulmonary benefits with Trikafta, with improvements in BMI, sinonasal symptoms, and something that's been a huge cause of anxiety for me, pregnancy rates. So we've had about 4 pregnancies in the last 12 months, 3 of which have occurred on Trikafta. And not sort of specific to Trikafta, but there's also improvements in pancreatic disease with modulator therapy. A little dodgy for me to have included this slide, but Stuart, it's now been referenced. So this is just a photo that I took from someone else's talk that I attended at the Thoracic Society of Australia and New Zealand conference recently. It was a physiotherapy PhD candidate, and Ms. Chapman had interviewed a whole bunch of CF patients that had started Trikafta, and these are snippets of a conversation with them. And they've sort of said unreal things like, I feel virtually unlimited in what I can do. It's pretty bloody amazing. And just being able to live. You don't really live when you're sick like that. It's not a life. I won't read them all out, but you get the gist. Now, this slide probably presents more problems than it answers. Despite all the promise that Trikafta has shown, it's not the cure for CF, and there are challenges to consider. Although it was pretty well tolerated in the studies that I mentioned, there are drug-related side effects to consider. Notably, initially there's a worsening of cough and sputum load. There are important GI side effects, a significant rash that sometimes results in treatment discontinuation in about 10% of patients, and increased LFTs. Many of our patients, even before the simplified trial came out, had already self-ceased their airway clearance practices, and not all of them necessarily fit into that sort of mild, stable lung disease cohort. So it has resulted in reduced compliance in our patients. Our CF patients have been told for most of their life that they can eat whatever they want, including high-fat diets. But with the improved absorption that Trikafta has shown, our patients are getting bigger, and previously we've had to deal with malnourishment, but we might have a bit of an obesity pandemic on our hands. We've had a few pregnancy-related issues. So, firstly, contraception is now something that we need to talk about a bit more. And in our pregnant patients, with the limited data that we have, do we continue Trikafta or do we stop it? Balancing that against the risk of exacerbation and poor lung function. There are, for the patients that have not been able to escape a lung transplant despite Trikafta, we have to ask ourselves if we would continue Trikafta for its non-respiratory, less well studied, but non-respiratory benefits. And there are drug interaction issues to consider here. Something for all of us to remember, Trikafta is a CYP3A substrate. And so when we're using particularly CYP inhibitors, we need to consider dose adjustments. And we often, Mark and I often get caught out by clarithromycin, but luckily Joelle's cleverer than we are and adjusts the dose. And Eli sort of talked a little bit about the improvement in our Mr. J.E.'s mental health, but there's also a bit of an interesting existential issue that our patients need to consider. These young patients never really thought they would make it to old age, and now they will, and so they have to consider things like relationships and careers and mortgages, and unfortunately, like we're not sort of well equipped in the adult world to help them deal with these issues. And then finally, although it's been a miraculous drug for a large number of CF patients, what do we do about those that have been left behind? Near the end of my talk, I just wanted to do a quick shout out to our amazing CF MDT team. We run 1.5 clinics a week. And it involves our amazing CF nurses that help coordinate the clinics. They're the point of contact for our patients as well, and help maintain a registry. We've got an amazing dietitian, Taryn, who manages all the malnutrition side of things, as well as vitamin replacement and parenteral nutrition. Our amazing physiotherapists as well that gently braid our patients about maintaining their airway clearance. Our social worker, Ellie, who provides a lot of counseling for patients and the emotional support that I'm not emotionally equipped to provide. And our endocrinologist, Dr. Peterson, who helps manage the diabetes and bone management side of things. But there is still a huge unmet need. We don't have an ENT or a gastroenterologist or a psychologist, and we know that our CF patients suffer from these from all of these things. So if there are any friendly gastros or ENTs in the audience, we'd love your help. And I thought I would just leave with this slide. This is Mr. JE's FEV1 graph after he started Trikafta. And you might recall from studies I presented, the mean predicted improvement in FEV1 was about 10 to 13% across those two studies. Mr. JE has had a whopping 45% improvement in his FEV1. And we've gone from talking about lung transplantation to completely normal lung function. And that's all I have.
Thanks. That was a fantastic presentation and it's brought us up to date with very exciting new developments. While we're waiting for questions from the audience, is there any reason why you need to use the 3 agents in combination? Is there a way that you can do a genetic assessment and say you only need one of them, because that surely will decrease the costs? That's my first question. And what's the nature of the molecular structure of these molecules? Are they, I mean, we're using a lot of immunoglobulins these days, but these are small molecules. And so what's their structure? Yeah.
That's a good one. In terms of can we just get away with one drug? I guess it's a little hard to answer. I mean, the second study that I presented compared 2 with 3, and 3 was clearly better. So I think that the drugs, like tezacaftor or the early correctors aren't enough to completely create a normal protein. But having said that, we probably do need to individualize therapy a little bit more. There are a portion of non-responders that I didn't quite mention. And one of the sort of interesting things in the future for CF is using organoids to identify who will really respond to these medications. So like the CFTR channel is quite highly expressed in rectal cells. So we do rectal biopsies, in vitro supply the biopsy with the medication and see what response we have. So that'll help individualize things a little bit more. But I think, yeah, we still need more than one agent. To be honest, I don't know the answer to your second question. I'm not sure about the sort of exact makeup of these molecules. I mean, yeah, small molecules, but I don't know exactly what they are.
No, okay.
Sorry, I looked it up.
But they're not immunoglobulins or anything.
No,
like that.
they're not. Yeah.
Okay. Ashwin.
Yeah, hi, Yash. Great talk. And thank
You
you. For
repeat the
Just a
question.
question about screening CF. So obviously we're doing the spot test, isn't it? But now we've got so many other genes that can cause the variants, rarer variants of CF. Who gets screened these days as adults for CF? And is it something that, do people request that and people over the
A repeat question.
So I guess the question was about screening and who gets screened as an adult in brief. So I mean, yeah, all children in Australia get screened. We look for the an elevated trypsinogen level, and if that flags, and if the pediatricians want to correct what I'm saying, because I don't actually do this, but I've just read about it. If there is an elevated trypsinogen level, then they'll go on to have genetic testing, and if or a sweat chloride test, and if the sweat chloride is intermediate, then genetic testing. In the adult world, screening is perhaps not the right term, because there's no point in screening unless you manifest disease. That's when it really becomes significant. And so we would test someone for CF if they have bronchiectasis and we don't know the cause. I mean, there's a classical upper lobe distribution of cystic fibrosis, and I'm sure that we'd all consider CF testing in these patients. We also encounter a lot of patients that have gone through their lives with normal lungs when they're unable to conceive. And then these patients will also get screened for CF, or tested for CF rather, but there's no sort of plan to screen in the absence of significant disease, because it's probably not relevant.
Yeah, I guess that's the other aspect is some people are carriers, right? So recessive gene, they may not have a positive test of but later on the market.
Yeah, things might change.
Yes.
I'm Laura, I'm the AMS pharmacist. I just had a quick question, Yash, about if you came across anything in the literature regarding the CFTR medicines and the impact on a patient's volume distribution. It's coming from an AMS perspective, I guess. We had a patient the other day who was on tobramycin and they had 10 milligrams per kilo previously, and now they require 7 milligrams per kilo after starting these medicines. My understanding from a few colleagues that I've spoken to is that these drugs lower the volume and distribution because they're having an impact on the sodium channels. And I was just wondering if you've heard of anything.
Can you repeat the question?
Oh yeah, the question was about whether or not these new molecules have any effect on volume of distribution. I haven't read anything. I hadn't thought about it, to be honest. What made you guys think that the patient needed a lower dose? Sorry, I missed that.
So when we test, we do TDM, therapeutic
Yeah.
drug monitoring.
Yeah. Oh, it was after. Yeah, sure.
They were on 10 milligrams per kilo, but they actually required a lower dose based on the AUC and the Cmax that we monitor for those drugs.
Yeah.
And we were just wondering if they were requiring lower dose.
Yeah. I'm not sure why that would be. I mean, like the channels that we're improving are fluoride channels. I'm not sure. Yeah, I'll look into that. Actually, that's an interesting point. Yes, sure.
Thanks for the lovely talk, Yash. Just wanted to ask, when is Trikafta indicated? Sooner the better, I guess, because you're trying to avoid long-term damage to the lung, and hence pediatricians are keen to know when to start. And I note the couple of studies that you mentioned, the age group was about 12. Is under 12 still a category?
Wonderfully controversial question, but really excitingly, I think in April of this year, PBS approved Trikafta for patients over the age of 6. But in the US, the FDA has recently approved Trikafta for patients 2 years and above. I agree. I mean, the earlier you start, the more lung function you preserve, but we're bound by costs. And so in Australia at the moment, it's only recently come about that it's 6 years. Bless you, did you have anything to add to that? Yeah.
That was very exciting and a lot of advocacy. So now we have Trikafta from age 6 and above, and hopefully in the next few months, from 2 and above, it will be quite helpful. It prevents long-term damage, but also has cognitive and psychological effects on growth and development, GI side effects. So, overall, it has patients, particularly the teenagers that we have on Trikafta, mentioned this amazing sense of well-being at school and social life and education, but also the ability to take a flow. So it's very exciting that you came in to see us at the right time.
I think so. Yeah. I don't know what all the fuss is. Yeah.
So there was a comment from the audience saying that Trikafta is available for people over 6, and it's life-changing medication. I think it's fair to say. There's a question on the web, and this will be the last question. Actually, there's a comment from Tim McDonald saying that it's indicated as soon as possible. But there's another question from Tony asking what is the cost and who pays. I think we know the PBS pays.
And it costs about $250,000 a year.
So the cost is $250,000 a year. Wow. And how many patients do we have on it?
So Australia, I don't know the exact number, but Australia, like I would guesstimate, I mean, Australia's got about 3,500 patients with cystic fibrosis, and 90%, or a bit less than I guess, would be eligible. So a big number, yes, so 3,000.
Yeah. Well, I think it's been a fantastic Grand Rounds today. It's been very exciting hearing about these new developments, and I'd like you to join me in thanking Yash and Eli for excellent presentations. Thank you.
I missed the second